Thank you for the invitation to present prediction of prevention of preterm birth in twin pregnancies. I have nothing to disclose. The objective of today's lecture is to discuss the incidence of preterm delivery in twins, the cervical length as a screening tool, and the different therapies available for the prevention of preterm birth in twin pregnancies like progesterone, pessary, and cerclage. The twin birth rate in 2018 in the United States was 32.6 per 1,000 live births. The preterm birth incidence before 37 weeks in twin pregnancies in 2018 was 60% compared with 8.2% in singletons. And early preterm delivery less than 34 weeks was 19.5% compared with 2.5% in singleton pregnancies. Twin pregnancies are 3.2% of all live births. However, they account for 20% of all preterm deliveries, and they have 5 more times risk of early neonatal death and increased morbidity and mortality rates associated with prematurity. Monochorionic diamniotic twins have a significant higher incidence of spontaneous preterm birth compared with diachorionic diamniotic twins, and they also have an increased incidence and risk of fetal indications due to inheriting problems with the monochorionicity. The cervical length in twins. The preterm prediction study published in 1996 included also twin pregnancies. 147 women with twin pregnancies were evaluated at 24 weeks and at 28 weeks. 50 potential risk factors like maternal demographics, biochemistry markers, and cervical length were evaluated. The study concluded that the cervical length at 24 weeks was the best predictor for spontaneous preterm birth before 32 weeks, 35 weeks, and 37 weeks. Multiple publications has evaluated also the cervical length in the prediction of spontaneous preterm birth in twin pregnancies, and this systematic review and meta-analysis published in 2010 included 16 studies symptomatic women with twin pregnancies, and they concluded that the transvaginal cervical length less than 20 millimeters between 20 to 24 weeks was the most accurate in predicting preterm birth less than 32 and 34 weeks of gestation. I like this publication. This is an IPD meta-analysis that included 12 studies, observational or participated in a randomized clinical trial from different countries in Europe, United States, Australia, and Brazil. And they included twin pregnancies that had cervical length from 15 to 28 weeks and had no interventions. They also excluded women with fetal anomalies, twin-to-twin transfusions, cone or lip procedures, or fetal demise. They included in the study 4,400 women and developed this table of predicted probability of preterm birth by gestational age when the cervical length was done and by the cervical length by millimeters. For example, if a patient had a 15 millimeters at 20 weeks, the predicted probability of preterm delivery before 28 weeks is 38%, and 39% of delivery between 28 to 32%, and only 6% will still be pregnant after 36 weeks. This table is very useful in clinic when we evaluated women with cervical length at the time of the anatomy. Cervical length is different by chronicity and increased risk of preterm birth. We evaluated 110 women with twin pregnancies from 2 randomized clinical trials that participated in the pessary study. Cervical lengths done between 18 to 23 weeks. We identified that the monochorionic twins had a mean cervical length shorter than the diachorionic twins and a higher incidence of cervical length less than 25 millimeters or less than 15 millimeters, and this was significantly different. When we compare the gestational age at delivery in weeks versus the cervical length in millimeters, we identified a mean difference of 2 weeks when we compare monochorionic pregnancies in red with diachorionic pregnancies in blue. We also evaluated twin pregnancies by mode of conception. We compare women with reproductive technologies, mostly IVF pregnancies, versus spontaneous conception. And the group that received infertility treatment had a higher incidence of shorter cervix and a higher incidence of spontaneous preterm birth with a median of 1 week when we compare reproductive technology versus spontaneous conception. In conclusion of the cervical length in twins, cervical length in twins is the best predictor for preterm birth at any gestational age. The shorter the cervical length and the earliest of the gestational age at the time of diagnosis, the higher the risk of preterm birth. Groups who are higher risk are monochorionic twins and those that have reproductive technologies for conception. Let's move to therapies for the prevention of preterm birth in twin pregnancies. We will discuss progesterone supplementation, pessary, and cerclage. Let's start with progesterone supplementation, 17-hydroxyprogesterone or vaginal progesterone. Unselected twins that receive 17-hydroxyprogesterone versus placebo, we identified 6 studies, including 1,963 women. There were no differences in the relative risk of spontaneous preterm birth at any gestational age that were evaluated, and only 1 study concluded a decreased risk in composite neonatal morbidity and respiratory distress in neonates. In unselected twins with vaginal progesterone, 7 studies were identified with 900 women, and there were also no differences in preterm birth or differences in neonatal outcome. Twins with short cervix and 17-hydroxyprogesterone, 3 studies informed, 2 of them were secondary analysis of the previous studies. There were no differences in the risk of preterm birth, or 2 of them informed of no differences in the neonatal outcome. Twins with short cervical length and vaginal progesterone was informed in 3 studies in the original publications. There were no differences in 2 of them, and only 1 informed of no difference in the neonatal outcome. The last study, the study published in 2016 from Egypt, included women with twin pregnancies and cervical length from 20 to 25 millimeters, and they informed of a decreased risk of preterm birth less than 34 or 32 weeks, and a decreased incidence in the neonatal outcome in mechanical ventilation, respiratory distress, and early neonatal death. The updated IPD meta-analysis included 303 women, included the study from Egypt, RAFI 2016, that provided 70% of the sample size. There was a statistically significant reduction in the risk of preterm birth less than 33 weeks by 30%. The vaginal progesterone in twins with cervical length less than 25 millimeters decreased the risk of preterm birth at every gestational age that was evaluated, and most importantly, it decreased the risk of preterm birth less than 32 weeks by 50%. The number needed to treat to achieve this outcome was from 6 to 12 women. The neonatal outcomes were also decreased. There is a significant decrease by 50% in the neonatal death and perinatal death, a decrease in composite neonatal morbidity and mortality, birth weight less than 1,500, and mechanical ventilation. There were, let's say, more impact on women who had cervical length from 10 to 20 millimeters. However, all women had a decreased risk of neonatal death by cervical length. The best dose of vaginal progesterone was 400 milligrams, with both decreased preterm birth and neonatal death. And there were no differences if the woman had history of preterm birth or not. This is the last study evaluating vaginal progesterone for prevention of preterm birth in twins, the EVANS trial. This is a double-blind, placebo-controlled, randomized control trial, 22 hospitals in Europe, a randomized 1-to-1 ratio, and they give 600 milligrams a day of vaginal progesterone versus placebo. The dose was 300 milligrams twice a day. They randomized and initiated the progesterone very early, from 11 to 14 weeks and up to 34 weeks. And the primary outcome was a spontaneous preterm birth between 24 weeks to 34 weeks. There were no significant differences in the outcome when placebo group in blue was compared with progesterone in red. When women who had cervical length were discriminated below or above 30 millimeters, women who had less than 30 millimeters of cervical length, 14% in the progesterone group and 11.9% in the placebo group, there was a significant decrease in the spontaneous preterm birth before 32 weeks. Here, the survival curve, placebo in blue and progesterone in red, but there was no significant difference in women who had cervical length more than 30 millimeters. In conclusion, for progesterone in twins, unselected asymptomatic twins, either intramuscular or vaginal progesterone is not recommended. Twins with cervical length less than 25 millimeters prior to 24 weeks, intramuscular progesterone is not recommended, but vaginal progesterone is associated with a reduction of preterm birth before 32 and 34 weeks and decrease in adverse neonatal outcome. There is currently no good data in women with twin pregnancies and prior preterm birth, and they should be individualized or included in the group with short cervix. Pessary for the prevention of preterm birth in twin pregnancies. In unselected twins, 2 studies included 1,988 women, and there was no decrease in the relative risk of preterm delivery at different gestational ages, and there was no decrease in the neonatal outcome. In pessary in twins with short cervical length, 527 women included in 4 studies. The first 2 studies in the Netherlands and in Spain, they inform a significant decrease of preterm birth at different gestational ages, and the Netherlands study informed also a decreased risk in poor neonatal outcomes. However, these findings were not replicated in the study by Nicolaides in 2016. They have the largest sample size of 214 women, no differences in preterm birth or neonatal outcome. A small study done in our hospital in University of Pennsylvania included 46 women with short cervix, and there were no significant differences in the incidence of spontaneous preterm birth. This is the cervical length, a randomization, and the rate of spontaneous preterm birth before 24 weeks at different cervical lengths. And when compared pessary with the control group, there were no significant differences in any of the subgroups evaluated. In conclusion, for the twins and pessary, in unselected twins, pessary is not recommended. Twins with cervical length less than 25 millimeters prior to 24 weeks had equivocal results in the studies from Europe, and the pessary may be associated with decreased preterm birth before 32 or before 34 weeks. And there is a current randomized study ongoing in the United States, and we are waiting for the results. Let's discuss now cerclage for the prevention of preterm birth in twin pregnancies. We will discuss history-indicated cerclage, ultrasound-indicated cerclage, and physical exam-indicated cerclage. The first trimester cerclage or prophylactic cerclage was only evaluated in 1 randomized clinical trial. They included 22 women in the cerclage group and 23 in the non-cerclage group. There were no decrease in delivery before 37 weeks or decrease in neonatal death. There was no, cerclage was not effective in prolonging gestation or improving fetal outcome in twin pregnancies. This retrospective study evaluating prophylactic cerclage in 146 women compared with 8,000 women that received no cerclage informed of an increased incidence of gestational age before 32 weeks, an increased incidence of low birth weight, and increased incidence of cesarean section. By the other hand, history-indicated cerclage in twins with a history of preterm delivery was evaluated in this retrospective match-controlled study, where 40 women that received cerclage were matched by maternal age, history of preterm birth, and year of delivery, and they were matched with the 41 controls. They inform of a significant decrease of preterm delivery at every gestational age, decreased incidence of a rupture of membranes before 34 weeks, and a prolongation in the gestational age delivery by 5 weeks. They also identified a decreased incidence of neonatal poor outcomes like low APGARs, admissions to the ICU, respiratory distress syndrome, decreased risk of neonatal mortality, and overall a decreased risk of composite adverse neonatal outcome. Ultrasound indicated cerclage. In 2005, this publication of meta-analysis of trial using IPD data, mostly dedicated to singletons, included 49 women with twin pregnancies. In this publication, they concluded that in this sample, the cerclage was associated with a significantly higher incidence of preterm birth at less than 35 weeks and a trend towards higher perinatal mortality. And this study has been cited in multiple other publications and in our practice bulletin, where a cerclage is not recommended in twin pregnancies. However, when these 49 women were evaluated in a more strict statistical evaluation, it was identified there were differences in the maternal demographics. There was a difference in the gestational age randomization and the history of preterm delivery. Also, only 13 women had cervical length less than 15 millimeters, 7 in cerclage group and 6 in control group. When the outcome was evaluated and a logistic regression was performed to correct for these confounders, there were no significant differences in any of the preterm birth deliveries at different gestational ages, perinatal death, or low birth weight when cerclage was compared with control. It was an increased risk of respiratory distress syndrome in the neonates in the group that underwent cerclage. However, there was no increased risk of preterm birth as informed in the previous publication. A systematic review and meta-analysis also included these 6 cohort studies. They concluded that ultrasound indicated cerclage decreased preterm birth before 34, 32, and 28 weeks, and a pregnancy prolongation by 2.3 weeks. And when women were evaluated with cervical length less than 15 millimeters, there was a significant decrease in preterm birth before 37 weeks, 34, 32, and a pregnancy prolongation by 3.9 weeks. There are a current randomized controlled trial. I am the primary investigator of this study, and I invited you to participate. This is a multi-center international trial, and we are currently enrolling. This is the algorithm for enrollment. Twin pregnancies are going to offer cervical length between 16 to 23 weeks. If women are identified with cervical length less than 25 millimeters, we offer them vaginal progesterone for 100 milligrams. If the cervical length is then that 10 millimeters, we offer them pelvic examination to determine if the cervix is dilated. If the cervix is closed and the cervical length is less than 15 millimeters and no other exclusion criteria, we offer them participation to the randomized controlled trial, cerclage versus no cerclage, and we continue with the vaginal progesterone. If women had cervical length between 16 to 30 millimeters, we offer them an additional cervical length to determine if they shorten over time, and they maybe are good candidates to participate in our study or candidates to have vaginal progesterone. Physical exam indicated cerclage for the preterm birth prevention in twin pregnancies. The same systematic review and meta-analysis included 3 cohort studies that compare physical exam indicated cerclage with control. And they identified a significant decrease in preterm birth less than 34, 32, 28, and 24 weeks, and a pregnancy prolongation of 6.7 weeks. This is the result of our latest publication, Physical Exam Indicated Cerclage in Twin Pregnancy, a randomized controlled trial. As we discussed before, the incidence of preterm birth in twin pregnancies before 34 weeks is 20%. However, when cervical dilation during the 2nd trimester is identified, it represents the worst prognosis for preterm birth. And then these twins with dilated cervix will, at 90% will deliver before 34 weeks. So we move from 20% risk to 90% risk of preterm delivery before 34 weeks. The objective of our study was to evaluate if physical exam indicators or class will reduce the rate of spontaneous preterm birth before 34 weeks of gestation and decrease the adverse neonatal outcomes in women with diagnostic twin pregnancy and asymptomatic cervical dilation from 1 to 5 centimeters before 24 weeks when compared with no-sir class in a randomized controlled trial. We excluded women with any other possible diagnosis that would increase the risk of preterm birth, including bulging membranes beyond the external os and class already in place. We calculated a sample size of 52 women, 26 women in each arm. Our primary outcome was the spontaneous preterm birth before 34 weeks, and secondary outcomes were spontaneous preterm birth before 32, 28, or 24 weeks, interval between diagnosis to delivery, composite neonatal outcome, and perinatal death. The patients were randomly allocated to 1-to-1 ratio to either SERCLASH or no SERCLASH at 8 institutions for 4 years. The primary analysis was an intention to treat, and the study has no external funding. Interventions like amniocentesis was offered to all participants, but it was not mandatory. The following therapies were at the discretion of the treating physician: amnioreduction, use of indomethacin, antibiotics, vaginal progesterone, surgical technique, additional tocolysis, maternal physical activity after randomization. Data and safety monitoring board was pre-established, and we performed an interim analysis when 30 women had been enrolled. They were 58% of the sample size. The board recommended stopping the trial due to significant differences in the perinatal mortality in one of the groups. There were 17% in one group and 77% in the other group, and that was very significantly different. Therefore, the request to unmask the trial. We identified for eligibility 70 women. We excluded 36. 22 women declined participation, and 14 had an exclusion criteria. We randomized 34 women. 18 women were randomized to SERCLASH and 16 to control. 4 women in the SERCLASH group did not receive the surgical procedure. One of them had vaginal bleeding posterior after randomization and required emergent delivery. The other patient had amniotic rupture of the membranes in the pre-holding area before going to the operating room. The other patient, the SERCLASH was attempted, but the surgeon determined that the cervix was too friable and determined that the procedure cannot be done. And the last patient changed her mind for participation and did not present to the operating room the next day after randomization. These 4 women were included in the analysis in the SERCLASH group as an intention to treat. We included for analysis 17 women in the SERCLASH group. 1 was included due to expired consent, and we analyzed 13 women in the control group, 3 excluded due to expired consent. There were no differences in the maternal demographics when we compared the SERCLASH group with the no SERCLASH group. There were no differences in cervical dilation and diagnosis, amniotic membrane prolapse, vaginal progesterone, or amniocentesis. Only 4 women agreed with amniocentesis, and the results were negative for infection. More women in the SERCLASH group received indomethacin, and all women received antibiotics. This is the survival curve. There was a significant differences in when we compare physical exam indicators SERCLASH in red with no SERCLASH in black, and the primary and secondary outcomes were all significantly different, with a decreased incidence of spontaneous preterm birth at 34, 32, 28, and 24 weeks. The gestational age at rupture of the membranes were significantly prolonged by 9 weeks in the SERCLASH group. The gestational age at delivery were almost 7 weeks different in the SERCLASH group when compared with the no SERCLASH group, and the interval from diagnosis to delivery was significantly prolonged by 5.6 weeks. The overall perinatal mortality rate decreased by 77%. The number needed to treat were from 2 to 4 women. The neonatal outcome was not significantly different. However, the sample size is very small. There were 30 survivors in the SERCLASH group and 6 in the no SERCLASH. In conclusion of the randomized clinical trial, a combination of the physical exam indicator SERCLASH indomethacin and antibiotics in asymptomatic twin pregnancies before 24 weeks, where significantly decreases spontaneous preterm birth at all gestational ages, prolonged time from diagnosis to delivery by 5.6 weeks, but most importantly, it decreased the spontaneous preterm birth before 28 weeks by 50% and decreased perinatal mortality by 77% with the number needed to treat less than 4 women. In conclusion of this lecture, the incidence of preterm birth and spontaneous preterm birth is 10 times higher in twin pregnancies than in singletons. Cervical length is the best predictor for preterm delivery at any gestational age. The shorter the cervical length and the earliest the gestational age, the higher the risk of preterm birth. Vaginal progesterone on twins with cervical length less than 25 millimeters decreases spontaneous preterm birth. Twins with dilated cervix before 24 weeks benefit from physical exam indicator cerclage. There is a potential benefit of ultrasound indicator cerclage in twins with cervical length less than 15 millimeters, and there is a potential benefit of pessary in twins with short cervical length. Future studies, we identified 7 current recruiting randomized clinical trials in twin pregnancies for the prevention of preterm delivery. 3 of them are evaluating pessary, 4 cerclage, 4 progesterone, and 5 of them are evaluated women with short cervix. We also need studies evaluating epidemiology of preterm birth in twins by maternal and fetal indications, by chorionicity, by use of reproductive technologies, racial disparities, and different management in twins with history of preterm deliveries between 20 to 36 weeks. Thank you very much. I'm available for questions, and this is my email. And if you are interested in participating in our randomized clinical trial, please let me know. Thank you.